normal circumstances, the AV node forms the only route by which atrial depolarization can enter the ventricles. In some individuals, however, an accessory conducting pathway connects the atria and ventricles. Many different types of accessory pathways exist. One of the commonest varieties directly connects atrial and ventricular myocardium. Such a pathway is often composed of myocardial tissue and lacks the complex physiological properties of the AV node. In the presence of an accessory pathway, the SA node discharges, and depolarization is transmitted by the abnormal tissue into the ventricular myocardium without the physiological delay characteristic of transmission through the AV node. Depolarization transmitted by the pathway spreads slowly outside the conducting system through a localized region of ventricular myocardium. Such early depolarization of a small portion of ventricular myocardium is termed pre-excitation. As this process is taking place, and following the usual physiological delay, the AV node allows the atrial depolarization wave to pass into the bundle of His. The great bulk of the ventricles is then depolarized by signals spreading in the conventional way through the branches of the conducting system. This wave eventually meets the accessory pathway mediated signal, and the two waves cancel each other out. Of themselves, these events have no clinical consequences, but can produce a number of findings on the resting ECG. Pre-excitation results in an early onset of the QRS complex. This is at the expense of the PR interval, which is consequently shortened. As the accessory pathway mediated depolarization of a localized region of myocardium spreads slowly outside the conducting system, the deflection it produces on the ECG is slurred and is subsequently overwhelmed by the signal from conduction system mediated depolarization of the main mass of the ventricles. The slurred early deflection in the QRS complex produced by pre-excitation is termed a delta wave. The presence of a delta wave on the ECG not only results in shortening of the PR interval, but also in prolongation of the QRS complex. These ECG features secondary to the presence of an accessory pathway are referred to as the Wolff-Parkinson-White pattern. If the Wolff-Parkinson-White pattern is accompanied by paroxysmal attacks of tachycardia, the patient is said to suffer from the Wolff-Parkinson-White syndrome. Why should an individual with such an accessory tract be subject to paroxysms of tachycardia? Well, note how during a normal sinus discharge, the two currents transmitted into the ventricles physically fuse. This not only ends the contribution of the delta wave to ventricular depolarization, but also of course prevents the depolarization wave transmitted through the AV node from re-entering the atria. We've encountered a situation like this before. As you learned in section 4, the existence in the heart of two communicating pathways with differing electrical properties and whose depolarization waves ultimately limit the extent of each other's transmission is the substrate for a re-entrant loop. In this case, the re-entrant loop can be triggered by a premature ventricular or premature atrial contraction. The re-entrant tachycardia generated under these circumstances is termed AV re-entrant tachycardia. In the example shown here, the patient has just experienced a premature ventricular contraction at a time when the accessory tract is permissive to transmission of current. Depolarization generated from the ectopic site is transmitted into and depolarizes the atria. By the time the atrial depolarization wave reaches the AV node, it is ready to transmit the wave into the conducting system and depolarize the ventricles. Note, however, that in this sequence of events, there is now nothing preventing the wave from re-entering the accessory tract and depolarizing the atria from below. In this way, a rapidly discharging, self-sustaining re-entrant loop is established between the atria and ventricles, giving rise to AV re-entrant tachycardia. There are a few useful points to note at this stage. Firstly, once the re-entrant tachycardia is initiated, the ventricles are depolarized in their entirety by the conducting system. This includes the region of myocardium previously depolarized by the accessory pathway. So during a paroxysm of AV re-entrant tachycardia, the delta wave disappears and the QRS complexes of the tachycardia are narrow. Also, during the tachycardia, the atria are depolarized by current flowing upwards from the ventricles in a retrograde direction through the accessory pathway. Therefore, if we can identify the P waves during the attack, we would expect them to demonstrate an axis directed superiorly. That is, we would expect them to be negative in the inferior leads. One further point about the P waves which will come in very useful in practice is their distance from the preceding R wave. At presentation, it may be difficult to distinguish AV re-entrant tachycardia from AV-NRT. AV re-entrant tachycardia generally results in faster heart rates, but as shown here, this is not always the case. There is another clue which you can use to try and distinguish these two narrow complex arrhythmias. You learned in section 4 that the P wave in AV-NRT may occur during or immediately following the preceding R wave, producing a pseudo S wave in the inferior leads. In AV re-entrant tachycardia, because of the much larger distances travelled by the re-entrant current, a macro re-entrant circuit, if identifiable, the P wave tends to occur later in the cardiac cycle and is often observed as a distortion of the ST segment. In the example shown here, the experienced eye can identify this negative distortion of the ST segment as a P wave. The negative orientation of the P wave in lead 2 and its relatively long distance from the preceding R wave is consistent with a diagnosis of AV re-entrant tachycardia. The distance between the preceding R wave and the subsequent P wave on any ECG is termed the RP interval. We will discuss the RP interval again when we tackle tachyarrhythmia diagnosis in the quiz section. For now, note that both AV re-entrant tachycardia and AV-NRT are usually short RP interval tachycardias. What this means is that if we define the cardiac cycle by the interval between two R waves, the onset of the P wave occurs in the first half of the cycle in both AV re-entrant tachycardia and AV-NRT. However, the RP interval tends to be longer in AV re-entrant tachycardia compared to AV-NRT, and this can help distinguish between the two. These are the characteristic ECG findings of orthodromic AV re-entrant tachycardia. The term orthodromic refers to the direction of flow of the re-entrant circuit entering the ventricles through the AV node. It is possible for an ectopic to establish a re-entrant circuit flowing into the ventricles through the accessory tract. This is an antidromic AV re-entrant tachycardia. In this situation, ventricular depolarization is transmitted outside the conducting system, resulting in an extremely dangerous broad complex tachyarrhythmia, which we will discuss in the quiz section.